All right, so let's start out here. We're going to talk about hip pain in athletes, especially groin pain. What do you do when you have a 19-year-old male coming in, right hip, anterior pain with hip flexion activities? What kind of things can be going on? And let's think about that while we go through some of these different topics with hip and groin pain. So, first topic is femoroacetabular impingement and labral tear. So, it's usually patients that are complaining of hip pain with hip flexion activities, and this is due to an impingement in the hip. So, the femoral neck kind of hits against the anterior edge of the acetabulum, and this may cause pain. And because the labrum is a structure between the acetabular socket and the femoral neck, you can imagine that can kind of get crushed between those two bones. And the femoroacetabular impingement can happen mainly due to a pincer lesion, which means the abnormal growth of bone on the acetabular side, or due to a cam lesion, which is more of an abnormal bone on the femoral side. And I would say that majority of patients have a combination of these. I typically see that more males tend to have a cam lesion, and more females tend to have a pincer lesion, but they all have this to a varying degree in a combination. Oftentimes when patients come in with hip pain and with impingement things, they'll usually complain of what's called the C sign. So when they come in seeing me and they kind of cup their hands like this to look like the letter C, and when I ask them, hey, where does it hurt? And they go, kind of right in here, doc, and they kind of get to the side of that hip and do that motion there. I usually kind of think, maybe this may be related to an FAI or a labor type of pathology. I think it's just a way for the patient to show that it's deeper inside the hip joint, and it's not just superficially kind of out in their trochanter bursa or somewhere else, that it's a deeper pain inside the hip joint. In terms of physical examination, every single patient, we always talk about doing everything consistently the same. So every one of my patients, because I have to rule out if this is due to arthritis or other problems, I always do a same exam. So the first thing I do is a seated external rotation, internal rotation in the office, and that's kind of my test for arthritis. If they got pain with this, then I think the problem is more arthritis related and not really impingement or other things related. So I would do an internal and external rotation. The second thing is I see a lot of patients that come in with greater choke bursitis. A lot of times it's funny because I get excited looking at their x-rays and see, oh my gosh, you got terrible arthritis or you got terrible cam lesion, and all they're saying is, doc, no, that's not what bothers me. It just hurts me right over the tip of the greater choke whenever I lay on it, and that's usually probably the more common thing that I see in my office, which has a fairly easy solution, which I just inject them with cortisone and have them go to therapy. The other thing that I also make a point of doing is a hip flexion impingement test. I just have them lay down and I kind of bend their hip up, and if they say, yeah, that's exactly it, that's what kind of bothers me, then that clues me into doing a little bit more of an exam, kind of get geared towards testing for femoroacetabular impingement, which would be, my money test is the fader exam. So that's the flexion, adduction, internal rotation. Sometimes it's called dynamic internal rotation test, but what I basically do is I flex their hip up 90 degrees or more, and then adduct the hip and kind of roll it across. And if they have pain with this, this is a test where if they have this, and even if the MRI is normal, I tell them you got a labral tear and you got impingement. There's no doubt about it, because that's usually the only thing that really would cause this pain in the anterior aspect of the hip with me doing this. Oftentimes when we get the x-rays, you can see a little pincer lesion as pointed up by that arrow, or a little aspherical femoral head and neck junction where you can see that there's a little bit of a cam lesion. The next step is usually getting an MR arthrogram, which usually shows the labral tear. This is an important point for the primary care physicians. A lot of times I get patients sent to my office that say, oh, I saw a bunch of other doctors, my primary care got an MRI, and it doesn't show a labral tear, but they wanted me to come see you for, to see if it's something else. So if you get a regular MRI, the accuracy of that test for a hip labral tear is only 42%. So it's less than a coin flip. So it's very important that if you are truly trying to assess for a labral tear in the hip, that you need to get an MR arthrogram with dye injected into your hip joint. This is just like in the shoulder. If you're looking for a rotator cuff tear, then a simple MRI is fine. But if you're looking for more of a labral tear, then that even in the shoulder, that requires that MR arthrogram to inject a little bit of dye so that we can see that signal cutting across that labrum a little better on this hip with that dye contrast in there. In terms of treatment for FAI labral tear, we often try conservative management with physical therapy for hip stretching and abductor strengthening. So it's very important that, the point of sending someone with FAI and labral tear to therapy is not so that we can regain more motion through hip flexion, right? I mean, they have a mechanical block And it's really more for pain relief and strengthening and stabilizing their hip, not really trying to regain motion that they say they cannot get due to the impingement. And then if that fails down the road, we're often doing a labral tear repair, acetabuloplasty meaning we shave down that little pincer lesion, and then femoroplasty meaning we shave down that cam lesion. And so this is kind of a typical setup with arthroscopy, and we're taking a little bird device there and taking off that neck lesion in that cam, and this is what it looks like in the operating room in terms of reshaping that femoral neck. The next topic is Coxa Saltans, or the popping hip. So oftentimes patients come in, and a lot of times, it's for the knee. People say, oh, well, my knee pops, and it's usually normal. It may be a plica band, or it may just be that some people just have joints that pop, and it's usually not a big deal as long as it doesn't cause pain. My knees pop all the time. I still play soccer, and I don't have any problems. But sometimes that popping may be due to a pathology, which may be an intra-articular loose body. Sometimes a displaced labral tear can cause popping as well. And then sometimes you can have a tear in your cartilage that may be popping with certain types of motion, and that may be bothering you. The other types of popping that patients can have is Coxa Saltans interna, or the iliopsoas popping inside the hip joint, and it usually snaps over the iliopectineal eminence or the femoral head. And often the treatment is, if it's not too bad, we rest, stretch, anti-inflammatories. Hopefully whatever's irritated from those popping episodes go away, and they may continue to pop, but as long as it doesn't cause you a whole lot of pain, we don't really do anything with that. And then if patients are continuing to have problems, we may talk about doing an injection to see if that can calm it down, and also to see if that could be a diagnostic for true hip pathology. And then if that doesn't work, then we do a little surgical release to go in there and just release that iliopsoas tendon. They may lose just a small amount of strength, but it usually gets rid of their pain very predictably. Another type of popping could be an external popping, Coxa Saltans externa, and that's usually due to a snapping of the IT band of the greater trochanter. And these patients often come in and they'll say, hey doc, I got this really cool trick, like I can make my hip pop, and they can actually show you very well in going from flex to an extended position, and they're able to show it to you. A lot of times it doesn't really bother people, but patients just want to get it checked out. If it does bother people, then we make sure they do a nice regimen of therapy, stretching out their IT band, correcting their weaknesses, anti-inflammatories, and maybe even an injection as a both diagnostic and therapeutic treatment. And then if that doesn't work, we can also do a little IT band release, whether that's open or arthroscopic. The results have been pretty similar, and that's what we're able to do for that. Other things that can happen in the groin that often can be confusing, sometimes all they had was just a little bit of an adductor injury, or they have an adductor tendinitis. So that's actually a very easily palpable muscle tendon kind of in the groin that if I just push it over that tendon, they go, yep, that's it, that's where the pain is, doc, especially when I'm having them abduct their hip passively, and I am able to palpate that and stress that area and they're having pain, then I say, hey, it's the fact that you got this adductor injury, it may be a little partial tear, and maybe more tendinitis, but the treatment would be doing, first letting it get better, anti-inflammatories, physical therapy, stretching, and then going from there. Rarely, these, if they're involving a true tear where it may have avulsed off with a piece of bone, sometimes we go in there and talk about fixing these, but that's very rare. Most of the times we'll let them heal with physical therapy, and sometimes it heals in a little bit of stretched out position, and it may actually prevent those injuries in the future if you do good therapy. In terms of apophyseal avulsion injury, so sometimes I get kids that come in that have pain, anywhere from 13 to 16 years of age. They say, oh, I'm in track, I'm doing hurdles, I started running and I felt the pain, or I was doing something, long jump, and I felt the pain. And a lot of times it's because the kids are still not skeletally mature, they have a growth plate that's inherently weak. And sometimes you can get injuries through that area. So in an adult, whereas they would get that tendon tear, in kids they usually get an avulsion injury where a small piece of that bone rips off the growth plate with the same kind of mechanism. And often they'll have the tenderness palpation and pain with passive stretch around that area. Again, for these patients, we're using rest, ice, anti-inflammatories, protected wear bearing. So a lot of times patients come in, they're like, oh my gosh, they told us at the ER that we gotta keep this brace on and that we can't put any weight on it and we gotta be on crutches. A lot of times when I see them, even if they have a pretty good size apophyseal avulsion injury, I always say, no, it's okay. You can use the crutches, weight bearing is tolerated, and as you start to feel better, you can wean off the crutches. As long as you're not stressing it and you're not causing too much pain through this area, that you're okay to weight bear and do things. Obviously, I would not recommend them running or doing other things while this is happening. And most of these kids, they're pretty resilient. You give them 4 to 6 weeks, they come back and they're ready to go back to sports and they get better. So So here's a couple of examples. One on the your left there is an avulsion of the anterior superior iliac spine there, and then the one on the right is the lesser trochanter avulsion there with the iliopsoas attachment. Next item, osteitis pubis. This is one of those very rare things that people talk about, but we often really truly see in clinical practice. It's an inflammatory process about the pubic symphysis, so oftentimes patients come in and say, I got isolate pain right over kind of the anterior aspect of my groin, and it's painful, discomfort, and it's often a diagnosis of rolling out other problems. A lot of times it can be a little bit confusing, and so we're working up things like sports hernia or adductor tears and strains, and a lot of times they're having just pain over that area, and when we get an x-ray, sometimes it can show a little bit of that irregularity and widening of that pubic symphysis, and that's how we make diagnosis. Fortunately, these all improve over time without doing anything too special other than some rest, anti-inflammatories, and therapy like most of the conditions. The next topic is sports hernias. Sports hernias are very confusing because oftentimes there's a lot of terms out there that are used interchangeably. The way I differentiate, just to keep it simple in my head, and I think this is a good technique for everyone, is to have a true hernias, right, which are hernias that come through the inguinal canal, through the opening, and that's the stuff that the general surgeons are dealing with, like kind of making a turn to the side and diagnosing those hernias. And so that's a true hernia. Sports hernias are hernias that occur in athletes that are usually involved in abdominal hyperextension and thigh abduction activity. So such as a soccer player trying to kick a long ball, or a field goal kicker, or a hockey player. Those are the ones that often get injured with this. And so in terms of the sports hernias, there's actually two different types. The one is Gilmore's groin, that was mentioned earlier, and that's more due to the weakening of the fascia. And so the repair for that is a little bit different than a true athletic pubalgia, which that is really due to the fibroneurotic plate disruption, kind of right at the pubic bone. And so they have a slightly different pathology in terms of what's going on, and a slightly different treatment method. And so from our standpoint as orthopedic surgeons or as primary care, we don't really need to differentiate it. I think it's fine as long as we differentiate between a true hernia. If it's not a true hernia, then it's a sports hernia. And then we don't really need to worry more about that after that. Then it's going to be up to the surgeons to be able to figure out which one it is and what kind of repair they're going to need to be doing. And so the exam to find the sports hernia is tenderness over the inguinal region and pain with valsalva and really resisted sit-ups. They should not be having pain with that, but oftentimes people, with athletic pubalgia and also Gilmore's groin, the sports hernias, they'll often have pain with this. And again, the important point about the hernias is that traditional hernias occur in the inguinal canal through the opening, whereas the sports hernias tend to occur more due to either a tear or a weakening on the canal floor, and that's where something may protrude. And in terms of the athletic pubalgia, it's really more of a tear at the fibroneurotic plate where the adductor muscles and the abdominal muscles attach onto that pubic bone, and it's a disruption in that pubic bone itself. Treatment for this, rest, ice, activities, therapy, and then depending on what's going on, down the road it may be a surgery, and it may be a surgery to go in there and repair the transversalis fascia that may be weakened and not completely torn, and they may oversew that. And then if the fibroneurotic plate is disrupted at the pubic bone, they may do a little adductor recession, or either a repair or a recession of the rectus muscle as well. Sometimes if they're having continued pain, some surgeons add in a decompression of the general branch of the general femoral nerve to decrease that pain. Here's one of the examples of a tear in the external oblique muscle. So it's not like a frank tear, but usually it could even just be a weakening where some of that tissue kind of protrudes through that region where there's not supposed to be a weakness. And then oftentimes what the surgeons will do is put in stitches in there to repair that and reinforce the weakened portion. So sometimes I would say there's not actually a true tear, an opening, but it's more of a bulging in that area due to that weakness. And a lot of times it's kind of oversewing that region to be able to reinforce that area. And that's pretty much it.